treat as much as you can first up.
Germany is a propofol country.
So welcome back to Endoscopy Essentials. We are in the middle of ablation. Welcome back, Rehan Haidry from London Cleveland Clinic. And we have discussed a lot about indications. I like that. And the preliminary conclusion, at least, was ablation. And we are focusing on radiofrequency in this session. Ablation for metaplastic Barrett, for dysplastic Barrett, especially high grade, try to avoid. There might be an occasional case where you see nothing.
Indeed.
But it's mainly metaplastic, and this is where it does best.
Yes.
So you have a variety of catheters, and please tell us concretely what your practice is, which catheter you're using, and how you go about it.
So the almost 9 out of 10 patients in our centre will have ablation with the radiofrequency ablation. So the company was initially Barretts that did the initial studies. They Covidian, and now it's under the umbrella of Medtronic. And one thing that has happened over the years is there's been an evolution in the different types of catheters that are available to us. So on the whole, there are 2 different categories, and each category will target a specific type of Barrett's esophagus. So they have what we call a circumferential catheter, which is a balloon, which is about 4 centimeters.
Do you have a slide for us?
Yeah, sure. So I will show you. Here we go. So you can see on this slide here the entire portfolio of the balloons that are available, Thomas. So the balloon-based catheter has made it very easy for us to ablate long segments of Barrett's very quickly, but also safely. Before, if you remember when we started, we used quite a cumbersome system. We used to have to size the esophagus with a balloon.
Oh yeah.
We used to take it out, then we had to choose on the shelf, do I do 18 millimeter balloon, 22 millimeter balloon?
You had a slight stricture and
so thank God they took that decision making away from us. They have a one size fits all. So with they call it the RFA Express, and you know the efficiency is in the name. It is express because it makes it quicker. So it's a self-sizing circumferential balloon. It has a 4 centimeter length, and it uncoils along its axis, and you get this circumferential ablation. So in most patients, that'll be the catheter we'll use first up, because it's a longer.
Because there is a substantial proportion of the circumference still with Barrett's?
Correct, or the first treatment they'll have, because they'll have long segment Barrett's. You want to treat as much as you can first up.
And does it matter how much squamous epithelium is left after resection? So if you have resected half and it has not shrunken, so you have half squamous, do you still use the balloon, and you don't care that you burn the squamous?
No, I mean, we do. There is some collateral damage, of course, when we use these balloons. But for that very reason now, there's a whole portfolio of what we call focal catheters that can address exactly the type of anatomy that you refer to. And historically, there was just one focal catheter. We used to call it the Halo 90, and the surface area of this was 20 millimeters by 13 millimeters, and it's like a paddle that you put on the tip of your endoscope, and you can see here on this animation here, it fits onto the tip of any standard diagnostic endoscope. And you can essentially just paint the Barretts with the device similar to the anatomy that you described, where you've done a resection and you have a hemicircumferential area of Barretts. They then made them bigger and thinner, and there's a 4 centimeter longer Halo Ultra now. So they have catheters that will cater for all different surface areas of Barretts.
But that brings me to the question: what's your cutoff for balloon versus focal? I mean, just roughly.
So we very rarely use the balloon now, and the reason for that is because we do more resection. So of course, in the patients with low-grade dysplasia, which we won't go into, they often have long segment Barrett's where resection is not going to be part of the algorithm. The balloon will be the default. But I have to say, Thomas, now, because we've become so resection heavy, for all the right reasons that we articulated to in the previous session, that actually my workhorse is the focal catheters.
Oh, I see. So like if it's at least half of the circumference is taken care of by resection and replaced by squamous, which is not always the case, but mostly, then you go to the focal device, more or less. Huh?
Indeed, because another consideration, Thomas, is stricture formation. Especially when you've done a resection, they already have some fibrosis. They will have a narrow caliber esophagus by default. You don't want to layer on top of that treating the neosquamous epithelium with ablation, and then they become symptomatic with the stricture. So the focal device has really become like the workhorse of the ablation devices, certainly in my hands.
There is one through the scope catheter, which is smaller. Do you use that, or is it too small?
We use it in bespoke indications. It's called the TTS, the through the scope. It's a channel catheter, and it goes through the working channel of a 2.8 channel endoscope. And it's quite malleable, so it means that you can treat around strictures. So in those patients where they have an asymmetrical esophagus because of reflux or caustic injury or resection-induced sort of asymmetry, where they're little islands or tongues of Barrett's, in those patients it's quite useful. It's interesting, the other indication that we used it in was in patients with GAVE in the stomach, where you want to treat around the interzero and the antrum. So that's where we use it quite a lot. But it's nice to have on the shelf, but we use it fairly infrequently.
Fairly infrequently. So and I understand the classical indication is not too much Barrett left, plus a difficult anatomy because it makes easier to get around curves and angles and strictures.
It's access. Yeah.
Okay, but seems to be fairly straightforward. And do you have a video showing us how you do that? How difficult is introduction, by the way? Any complications there?
Yeah, so I would always advocate that your patient is sedated. So, we have this sort of dichotomous practice in the UK, for example, where, getting deep sedation is historically been difficult, but it's not nice to put this down the back of the throat of someone who's just had
Germany is a propofol country. So.
Well, you've set the bar very high. But it's sedation. Yeah. It's a very safe procedure. I always say to the fellows, safe, comfortable patient, comfortable endoscopist. And so intubating with this is quite straightforward. And, this is an example of a patient who's had an endoscopic resection, and you can see there's just a little bit of Barrett's left. Asymmetrical amount of Barrett's on the right wall here. So this is a perfect patient for focal ablation. So in this case, the first thing that you need to do, like we would always do, Tom, just make sure we don't miss anything before you run in with the ablation. So here I'm having a look. I've put some
even at the second
acid.
look, you had a first stepwise biopsy and everything, but that's an important message. Always look again.
Exactly, and then what we do is we spray N-acetyl cysteine as a mucolytic agent to just remove that invisible surface there. And then here you can see the focal 90 device, which is on my endoscope, and it is able to just paint the Barretts in a very systematic, stepwise manner, and you get this coagulum forming. You can see it's like a sort of grilled chicken appearance. And then, sometimes if you want to make sure, you can clean the coagulum away so you can see the areas that you've burnt, and then you can do a second ablation. So you get this nice homogeneous treated area. And so this is a 5-7 minute procedure, and the patients will go home the same day on some acid suppression and pain relief. So, that's an example of a, very straightforward focal ablation.
But maybe we can go more into detail. So you have your pedal here. You start at the left or right side of the Barrett. You burn, and then you move to the right, or to cover the entire Barrett. Do you then pull the endoscope out and go in with a cap to clean it and see what's left and do the second round, or how is it done nowadays?
So the really important point is when you ex vivo put the catheter on it goes in the 6 o'clock position. So when you're looking at it on the endoscopic screen, of course it's flipped, so it'll always be in the 12 o'clock position. Whenever we use a focal device, the learning and the teaching is you must always treat the esophagogastric junction as well as all the visible Barretts. And that's something we didn't used to do long ago, Thomas, when we started. And what used to then happen is we would find these missed areas of dysplasia around that sort of hot zone around the OGJ and get recurrences. And as soon as we started to treat around there, those rates went down. So I always say that we start at the esophagogastric junction and have a plan.
Including cardiac folds, why not?
Exactly,
Yeah?
exactly, because that is an area of uncertainty. And so I always say have a systematic plan. I always start in the 12 o'clock position. And then it's just a matter of using your big wheel and your left hand coming down and just torquing your endoscope, and your body will go around the clock face, and you'll go 2, 4, 6, and then if you can't, then you can come back, and then you can go in the contralateral maneuver and just comb the esophagus and treat, and then pull back. We don't extubate the patient with the device once we've done that. All we do is the rim of the catheter is blunt, so that in itself can act
so
as
you can scrape off.
Exactly, it's like a pseudo cap.
Instead of a cap. Okay, but you usually do a second round.
We'll always do a second round. The dosimetry for how we have treated over the years has changed in terms of the energy delivery, and now there's a consensus that actually just using 12 joules and just doing 3 applications, one after the other, is sufficient, and actually we don't need to clean. Some of us are still a bit more old school, and we like to clean to see that we've done the deed. But the latest publications from the Amsterdam group was actually you just need to do 12 joules, 1, 2, 3 ablations, and you don't need to clean or do anything. You can come back out
on
again.
one spot.
Indeed.
1, 2, 3, next spot.
Indeed.
And you're done.
Exactly.
And you're doing it in a circular fashion. So you're covering the circumference as long as the panel is, and then you go up to the next level. And
with a little bit of overlap,
Yeah.
just so you don't undertreat.
as far as you can precisely see it.
Exactly.
But that's why sedation is so important, because if the patient starts belching, and then you see nothing.
It's a painful procedure,
Yeah.
where it's a thermal injury to the mucosa, and often in recovery, we will make sure that they have had some alfentanil or some pain, because it can be quite painful for them.
It's quick, but you have to be very careful as well. And do you, at the end, if you don't routinely scrape it off, how do you make sure you have covered everything?
We know that one ablation is not going to treat all the Barretts. So I think that's an important teaching. Of course, we want to be as rigorous as possible, but we know that there will still be residual Barretts. Even if you've ablated just by the nature of neosquamous formation, we know that some places will get squamous regeneration, some won't. So ultimately these patients will come back at 8 weeks, at 10 weeks, at 12 weeks, and there will be little patches of Barrett's that you can retreat. And they will be more apparent then. So sometimes actually we don't want to over-treat, because then we run the risk of stricture formation.
So the message is, of course, after some experience, if your gut feeling tells you I've got 90%, don't push to 95.
Call it a day,
Yeah.
and, they'll come back in 8 weeks, and then you can finish it off then.
How many sessions do you do usually in a Barrett, which is not too long, let's say up to 5 or something?
So
it's like 2, an initial one, a good one, but then cleaning up the rest. The
exactly. So in the UK registry, where the median length was about 5 or 6 centimeters, we showed between 2 to 3 sessions. I think the median was 2.1 sessions. So that's how I counsel my patients at the start, to say, we're going to get to know each other quite well, because this is not a one and done, but normally you're going to need between 2 to 3 sessions. And please don't stop taking your PPIs while we're doing the ablation, because that will make things very difficult for us.
Any tips and tricks, difficulties with a focal device? I was asking about introduction.
I think that intubation sometimes can be quite difficult in these patients, and so one of the tips that I sometimes use, I'm just going to show you this video here, is if it's difficult to intubate, we use the dye spray catheter almost as to railroad the device through the cricopharynx. So if I may just play this video, you can see this is a similar patient with a short segment of Barrett's, and they had a bit of cricopharyngeal spasm. So what we do here is place the catheter in the mouth, and just use the dye spray catheter that we've used just a few moments ago to do apply the mucolytic agent, just to use that, just to help railroad the scope in. It's easier for the patient. You're not pushing and getting trauma. The anaesthetist doesn't get
like
angry with you.
Plastic guide wire.
Exactly.
Yeah.
So that's a little tip that I was taught by Jacques Bergman 10, 12 years ago. And I suppose my other tip is just don't overtreat. If you're not sure that you've done 2 or 3 or 4 treatments, just stand back.
Okay.
Because this can cause strictures.
And the patient, as you said, is coming back anyway, and then you can clean up, even if you have to clean up more than you would have hoped.
Exactly, and
it's not a disaster. The other extreme is worse, because then you cause a stricture.
And it's almost a whole session on stricture management after Barrett's endotherapy. They can be really refractory.
Yeah.
Sometimes they don't just need one dilation, or they often will need serial dilations. And then, because then also, Thomas, you're pausing their treatment while you're doing the dilation therapy.
The overview gets worse.
Strictures in Barrett's, not just ablation, but endotherapy per se, can be very, very stubborn.
And of course it's experience, but it's better, a slight undertreatment is better than an overtreatment of any kind.
Of course, I would agree with you totally, because we're not treating cancer here. We're treating dysplasia, so there's no rush. And I think I've learned that over the years, and it was teaching those is an undertreatment is absolutely fine. Completely different to what we advocate with resection, where undertreatment is unacceptable. You resect as much as you can, and maybe a little bit more. But in ablation, you do the exact opposite.
Okay, that's a good message, and brings us to the intervals. Is it that longer intervals have a lower stricture risk, or is there a certain cutoff, like you said, 8 weeks, where it doesn't matter anymore whether it's 12 or 16?
The intervals between the treatments haven't been shown to influence stricture rate. If they're going to stricture, they often stricture early on. Our nurses will phone them, and at 2 or 3 weeks they'll say, Professor Roche, I can't swallow now. Can I come back, please? But in all of the studies that we did, and also practically in terms of service delivery and organising your schedules, every 8 to 12 weeks is fair. And of course, some patients will come back a bit later. But you want to try and get that. All the studies showed that within 12 months, if we did these protocolized treatments, that we would eradicate dysplasia, and then they can go into a surveillance arm.
And that starts 6 months later, after you think, you have your islands and you are pretty confident that you killed all of them. Then you say there's a likelihood the treatment is finished, but you have to prove it on the next follow-up, which is how long, 3 or 6 months?
Yeah, between 3 to 6 months. They ought to have, at least 2 negative biopsies. And by negative biopsies, I mean biopsies showing no dysplasia, but also no Barrett's. So I think once
you also rely on biopsies. So if because there's the current Amsterdam view is that if I see nothing, there is nothing again. And
they still biopsy the cardia, I think, around the neosquamous, junction. We all used to take all these unnecessary biopsies from the neosquamous epithelium because we were worried that we'd buried Barrett's, but actually the yield of those was negligible. So we still, of course, as you said. It's such a good point that you've made, is look, just back to basics, look. But we still do take biopsies at the neosquamous junction. And then after 2 negative biopsies, we then confine them to 2 things. One is we tell them, good news, you don't have Barrett's, your risk of cancer is, almost the same as the background population. But the bad news is you still need to come back for endoscopies, because they think I'm done now. And those intervals will vary depending on lots of different factors, but often they will come back, every 6 months or annually for endoscopies, because even though the risk is low, there is a recurrence risk, and it's been looked at in many different studies, probably about 5%. So
5% neoplasia and 30% metaplastic, whatever that means.
And so if they're fit for endoscopy and fit for retreatment, well, then they're fit to have
Mm-hmm.
post-treatment surveillance. That's how I consider it.
Which is the current line of debate, right? So the Jacques Bergman, less is more, and do we do too much and patients die for other reasons? But then that's a highly individual decision. So you have to discuss with the patient, well, the risk is now very low again, so what do we do? And if, of course, it's easy if the patient is 85.
I think it's such a valid point that you make.
It's still, it sounds so easy, but there's still a big gray area, because it's not easy to say to a patient, you are too old for a follow-up.
Well, we can't say that anymore because
That's discrimination.
It is, but also, we all have senior patients with Barretts who, still play golf and, walk 10 miles a week. So I think your point is really well made, is that we can be algorithmical about this and say that you need to do this, but ultimately it's that interaction with your patient, isn't it? It's what's best for them, what's practically best for them, what's actually going to make a difference to their longevity. And actually some patients, if they're 85, I'll just, shake their hand and say, look, you've done the hard work and, enjoy your retirement.
That's right. I think my experience is if you really discuss this in detail, most patients have an opinion. And
Of course.
they said, thank you, if this is my residual risk, I will never show up again, and risk is risk, goodbye, huh?
Exactly. And,
Or they say, oh no, I have cancer. And
but as you said also, Thomas, you made a good point, is these patients don't just have Barrett's. By the very fact they have Barrett's, they'll have metabolic syndrome, they'll have a cardiovascular, they all will have a degree of insulin resistance that will drive other pathologies that will ultimately accelerate their demise. It won't be their Barrett's metaplasia.
Okay, Rehan, I enjoyed it very much. We were a little bit technical, but we always come back to general indications and almost philosophical considerations. I'm very grateful. Thank you very much.
It's been a real pleasure. Thank you so much for having me.
And thank you for watching and listening.